Hi, everyone. Thank you so much, Carlos, for your invitation to discuss the infectious diseases approach to patients with possible acute flaccid myelitis. As Janet Roth has mentioned, and I've borrowed the slide from her, there's a large overlap of both infectious etiologies and non-infectious etiologies of illnesses that affect the spinal cord. And many patients can present initially without a clear picture, which makes us need to consider both of these other causes other than classic acute flaccid myelitis. So the first step we often will take is looking at the clinical scenario, and particularly with our neurology colleagues looking at the imaging. And I have here the main differential diagnosis from the standpoint of the neurologists, whether this is an acute poliomyelitis picture, a transverse myelitis picture, or a Guillain-Barré picture, and also the possibility of something like botulism that doesn't have findings on CSF or on spinal cord imaging. But even if we find a patient who has cord involvement, it often is not clear if it has the classic gray matter predominant pattern that puts us in a more narrow differential diagnosis, or a more diffuse involvement such as we see in transverse myelitis, which has a very broad infectious differential. So in any infectious disease consultation, we start with the history and physical findings to help us think of potential causes that are unusual or that might point us in the right direction in a patient with an unknown disease. And this will start with symptoms such as respiratory or diarrheal illnesses in a patient who's presenting with flaccid paralysis, and also the timing of which their respiratory or diarrheal illness occurred before onset of their paralysis. We're very interested in travel, such as international locations, but also regional destinations within the US that might put them at risk of endemic fungi that are specific to those areas. We're very interested in tick and mosquito exposures, animal exposures, specific food or water exposures, any known sick contacts or sexual exposures, because as you'll see, these point us into certain directions with regard to the infectious differential diagnosis. And then vaccinations can also lead to post-infectious or post-inflammatory changes. So we get a very clear history of any recent vaccinations, or if they're unvaccinated and are at risk for vaccine-preventable illnesses. On physical exam, we're very focused on the skin examination and particular rashes, such as vesicular rashes, such as that might point us in the direction of a herpetic disease, or embolic lesions that point us in a non-infectious or fungal etiology. And then on the intraoral exam, we're interested in the classic Coxsackie enanthem or other oral lesions that might make us think of certain viruses, or hepatosplenomegaly, which might point to a more infiltrative disorder, or for instance, a fungal infection. So as I mentioned on the first slide, it's much more common when a patient first comes in to not be 100% clear if this is the classic anterior horn poliomyelitis picture when a patient comes in with paralysis, and more commonly the more diffuse or possibility of both gray and white matter involvement is entertained, and that implies possibility of transverse myelitis. And unfortunately, the infectious differential diagnosis of transverse myelitis is quite broad, encompassing viral, bacterial, fungal, and parasitic causes. I've highlighted in red those that we are most concerned about because they have an actual intervention, and I'll get to that on the next slide. But let's go through some of the viruses that have been associated with transverse myelitis, either with direct infection or post-infectious etiology. So the enteroviruses, of course, you're very aware of with our discussions with acute flaccid myelitis, but also parechovirus, all of the herpes viruses, flaviviruses, and in particular West Nile virus, Zika virus, and Japanese encephalitis virus, but also other arboviruses such as Powassan, parvovirus, HIV, hepatitis B, measles, mumps, rubella, and some of the respiratory viruses rarely have been associated, including flu and adenovirus. Of the bacterial etiologies, Lyme is the most common that we would encounter, but also syphilis, TB, actinomycosis, and mycoplasma. And in the fungal etiologies, not only the endemic fungi such as cocci-blasto and histo, but also aspergillus and cryptococcal disease. And the parasitic causes are less common, but include toxoplasma, cysticercosis, schistosomiasis, and angiostrongyloides. If we are lucky enough to have a much more clear picture on the imaging of a true anterior horn or central gray involvement that is very suggestive of a poliomyelitis-like picture, the infectious differential is much smaller than the discussion we just had for transverse myelitis, and is really focused on the enteroviruses, including poliovirus and the non-poliovirus enteroviruses and the flaviviruses, including those that we've already mentioned on the prior slide. Most of the infectious differential we've discussed does not have a targeted antimicrobial therapy, or even if it does, it's not necessarily emergent that it be started on the spot when a patient presents. But the key exceptions to this are herpes simplex virus and Lyme disease, where we do want to start therapy very rapidly for concern of deterioration if therapy is withheld. So for this reason, most of the patients that we see that we're seeing with acute flaccid myelitis and the differential do get started on intravenous acyclovir as well as intravenous ceftriaxone while we're obtaining the initial laboratory evaluation. And the laboratory evaluation we obtain could be quite extensive, particularly if it's not clear that it's a anterior horn involvement only, and we're doing the broader differential for transverse myelitis. And this could include serum samples such as serology for West Nile, the herpes viruses, VZV, CMV, and EBV, as well as Lyme antibody screening and reflex Western blot testing. Our respiratory and CSF samples, we're in most centers now are doing multiplex PCR, which includes multiple pathogens, but the ones that we're specifically interested in because of the differential include enterorhinovirus on the respiratory PCR, adenovirus, and influenza. And on CSF, we're interested in the enterovirus, the herpes viruses in particular. We also will send CSF antibody for West Nile virus, IgG, IgM, and also Lyme antibody, and we'll often do a concomitant serum test so that we can look at indexing between the serum and the CSF to see if there's specific antibody synthesis within the CSF to support a CNS infection. We will also obtain samples from the GI tract to look for shedding of enterovirus from both the nasopharyngeal throat or rectal swabs. And most importantly, the earlier we collect samples that can also be shipped off for the CDC molecular testing, the better. We don't want to miss the opportunity to identify these pathogens by their advanced sequencing techniques. So this is another slide from Janet Routh from her AFM update that really makes the point that if we don't find a pathogen, we are not in any way swayed away from the diagnosis of AFM. And in fact, the minority of patients will have an identified pathogen if it is acute flaccid myelitis. So this just makes the point that only 3% of CSF, 15% of stool, and less than 50% of respiratory specimens will yield a diagnostic test from infectious evaluation in patients with AFM. So it's really the reason we're doing these other tests are to make sure that we're not missing a different infectious diagnosis that is masquerading as AFM. So at Children's National, we've had 17 patients that we've looked at who've had an average median age of 6.4 years of age. The majority had pleocytosis and single limb weakness, but have had other presenting neurological symptoms, including generalized weakness, ataxia, or lower extremity weakness, or ophthalmoplegia. And of these patients, we've had a positive infectious workup in 8 of 17 cases, the majority with enteroviruses. So there are 5 patients who had either Coxsackie-B, enterovirus A71, or an unspecified enterovirus isolated from various sources, as noted there. And then we also have had patients with West Nile virus, parvovirus, and parechovirus detected from our infectious evaluation. And this just makes the point that in the CDC data of now 596 cases, only 4 have actually had the pathogens identified in the CSF, and you've heard a lot about the science behind looking for other pathogens with different advanced techniques. So in closing, I'd like to thank all of the Children's National teams that work very hard to respond to emerging infectious diseases, including our Special Pathogens Isolation Unit and Response Team and their Ebola and COVID work, our Infectious Disease and Infection Control Division for the work they do every day, our Zika program, and our Acute Flaccid Myelitis Task Force, which is multidisciplinary and really focused on the care of these patients. And we really look forward to additional collaboration with the larger multi-center working group. Thank you so much.